Okay, you said. Okay, so Assalamu alaikum everyone. My name is Shahd Alheijani. I'm a second year, and today I'll be giving you lecture 16 from MOL, Metabolic Defects in Amino Acid Metabolism. Inshallah, it's an easy lecture, and I try to simplify it as much as possible. And let's get started. So we'll be discussing the pathways of several amino acids for the metabolic defects. First, we'll start with the phenylalanine and tyrosine pathway. And under that, we have three main diseases. We have phenylketonuria, we have albinism, and alkaptonuria. Then we'll move to the pathway for the branched chain amino acids. And under that, we have maple syrup purine disease only. Then we'll move to the pathway for valine, isoleucine, methionine, and threonine. And for that, we'll be discussing two diseases. We have methylmalonic aciduria and propionic acidemia. Then finally, we'll be discussing the methionine pathway with homocystinuria. If my voice is not clear, please stop me and let me know. Okay, so before getting into these diseases, let's take an overview. Okay, so 1 second. Okay. So we said we'll be discussing metabolic defects. So what does that mean? First, it's basically inborn errors of metabolism. What causes those inborn errors? We start with mutations in the gene. So this mutation could either be a point mutation, deletion, or splicing error, for example. Can you guys see my cursor? Or it's not visible. Can you see it?
Yes, we can.
Okay, good. So these mutations could either be point mutations, deletions, or splicing errors. Now, those genes are normally coding for specific enzymes in the pathway for a specific amino acid. So if this gene is altered due to the mutation, it would affect the structure of the protein and hence affecting the enzyme itself. Now, since these are inborn errors, this means we can screen for them in the neonates or in the infants. So why do we screen? Why do we screen early for these diseases? This would help us interfere early and prevent the progression of the disease into worse outcomes. So, for example, in phenylketonuria, if we don't interfere early, the patients undergo, for example, mental retardation, and we don't want that. So if we screen early, we can interfere by dietary restriction, for example, as you can see here. So we could control their diet, decrease the phenylalanine in the case of phenylketonuria, for example, and this would prevent the progression. Now, we said there will be mutation in the enzyme, mutation in the genes altering the enzyme. So when this enzyme is altered, there will be either total loss of the enzyme activity or a partial deficiency. But in both cases, the catalytic activity would be affected. Now, what does this mean? Now, the enzyme would normally take the substrate and convert it to a product. If this enzyme is not working, this pathway will be inhibited. So the product will not be formed. Now, what's the problem here? When the product is not formed, the substrate will start building up. Now, when the substrate accumulates, it would cause it would start causing problems in the body. So it can either cause smell in the urine, for example. This happens in maple syrup urine disease. Now, from the name itself, you could tell that the urine would start smelling like maple syrup. Or it could cause somatic symptoms. So these symptoms would include either, for example, the patient would start experiencing seizures or alteration in muscle tone, or in severe cases, it could cause CNS effects and intellectual disability. Okay, now we can move to the diseases themselves. Now, for each disease, I tried adding a photo. I want you to associate this defect with this photo. We'll be labeling it soon, but this would help us visualize the presentation and what's basically happening. So for phenylketonuria, I want you to remember this guy. Now, we said phenylketonuria is one of the diseases or the defects happening in the phenylalanine or tyrosine pathway, so remember that. Okay, let's start. It's the most common inborn error of amino acid metabolism. Now, let's look at the pathway here. Wait.
Go ahead.
Yes?
Someone is asking if you can do a laser pointer.
Sorry, okay.
Thank you.
Okay, can you see it?
Yeah.
Okay. Sorry, I can't see the chat, so okay. Now, this is the pathway we have. We're starting with phenylalanine, and we want to convert this to tyrosine. This is the normal pathway. But what happens here, yes, and this pathway would need an enzyme called phenylalanine hydroxylase in the presence of tetrahydrobiopterin. So we need these two things to convert phenylalanine to tyrosine. Now, what happens here is either phenylalanine hydroxylase is deficient or tetrahydrobiopterin is not available. So if one of those two is affected, we can't convert phenylalanine to tyrosine. This would cause phenylalanine to build up, causing phenylketonuria. So we'll be discussing both defects in the coming slides, but remember that for now. Okay, so we also have something called aspartame. Now, aspartame is found in artificial sweeteners in Diet Coke, Diet Pepsi. So this is a compound containing phenylalanine. So if you imagine a patient having a defect in this pathway, so either phenylalanine hydroxylase or tetrahydrobiopterin are deficient, and we're giving them substances containing phenylalanine. So we're increasing the demand for this pathway, we're increasing the stress here. So we want to convert more of this into tyrosine, but the enzyme is not available. So this would cause even more severe effects. So this makes sense. So aspartame must be strictly avoided by phenylketonuria. Now this is the diagram I was talking about, but let's go over the pathway itself. So we said we have phenylalanine converted to tyrosine, and then tyrosine could be converted to other products normally. But what happens here is phenylalanine hydroxylase would be affected. So this pathway would stop. Now phenylalanine would start building up. So it would take another path now. It would go to form phenylpyruvate, forming phenylactate, and so on. Now phenylpyruvate and so on, those substances are phenyl ketones. When they start building up in the urine, from the name, you can tell phenylketonuria. So we have phenylketones in the urine. So this is the first symptom here. You can see it, increased phenylketones in the urine. Now we have other symptoms. We have hypopigmentation, so the skin would look yellow or pale. And most importantly, we have mental retardation. So you can see there are severe effects of phenylketonuria. What does this mean? We need to screen the neonates to check if they do have this deficiency, so we can interfere early. And how can we interfere? By decreasing phenylalanine in the diet, so we could decrease the demand for this pathway. And it's an autosomal recessive pathway defect. Now, this is the first thing. So we said phenylalanine hydroxylase could be affected. What could be affected too? We said we also need tetrahydrobiopterin. Now, how do we get this substance? Now, tetrahydrobiopterin is a molecule formed from dihydrobiopterin. So we need to add hydrogen to this dihydrobiopterin to form tetrahydrobiopterin. And for that, we need an enzyme called dihydropteridine reductase. So this enzyme is needed to form tetrahydrobiopterin, which would then go to help with this pathway, phenylalanine to tyrosine. Now, defects in dihydropteridine reductase will result in reduced activity of any enzyme requiring tetrahydrobiopterin as a cofactor. So if this is deficient, this will be deficient, so this pathway can't work. So what would happen? Phenylalanine will start building up again. So when it builds up, we have a hyperphenylalaninemia, and again, this would cause phenylketonuria, but the problem is not in the enzyme itself, but in the cofactor. Now, patients with dihydropteridine reductase defects do not respond to dietary restrictions as effectively as normal phenylketonuria. Why? Because tetrahydrobiopterin is needed for so many things, for forming many neurotransmitters and for folate and so on. So the effect of controlling phenylalanine would not be similar to normal phenylketonuria, which is phenylalanine hydroxylase deficiency. Now, we're done with phenylketonuria. We'll move to albinism. Again, albinism is still in... Yes?
A question in the chat.
Okay.
I was asking how does PKU? Yeah.
Okay, how does PKU? phenylalanine to tyrosine. Okay, so it's not about accumulating and damaging the neurons itself, but this pathway, phenylalanine to tyrosine, is needed to form many neurotransmitters. These neurotransmitters are needed by the brain for several actions. Everything working in the brain is depending on those neurotransmitters. So if this pathway cannot continue and you can't form tyrosine, you won't be able to form the neurotransmitters which are needed by the brain itself, which means this would affect the brain and again causing mental retardation. And again, accumulation of phenylalanine would also be toxic, which means we need to avoid aspartame, we need to decrease phenylalanine, so to prevent the toxicity of the substrate itself. And again, because the pathway is normally needed for neurotransmitters. I hope I made it. Any other questions, or should I move to the next point? Okay, so I guess there are no more questions.
Clear.
Thank you. Okay. Now to albinism. Again, we're still in the same pathway, phenylalanine and tyrosine pathway. This one is the easiest one. So again, it's a defect in the tyrosine metabolism pathway, but here we have a different enzyme affected. So again, with the same pathway, you have phenylalanine to tyrosine, but what is affected here is this step, tyrosine to melanin. And the enzyme needed here is called tyrosinase. The tyrosinase enzyme, if it's deficient, we can't form melanin. And we know that melanin is the pigment needed in the skin. So in its absence, you can see here the patient would look pale and with white hair and red eyes. So albinism is inherited by a different mode of inheritance. Now, since the doctor didn't mention it, you don't need to go into details, but albinism has different types. So you have the oculocutaneous, ocular, and so on. It could be either autosomal recessive or sex-linked, but you don't have to go into details. And tyrosinase is the rate-limiting enzyme for controlling the production of melanin, as I mentioned previously. That's everything you have to know about albinism. It's the easiest one. Any questions? The albinism is bad. It's mainly about the appearance, because they didn't mention anything about any mental retardation or so on, because the pathway affected would affect melanin, which is just the pigment. I'm honestly not sure if it has more serious side effects, but I'll be sure to research that and let you know. I'm honestly not sure. Okay, so any other questions? Okay, so we're done with albinism. Now we move to alkaptonuria. Now I didn't find an image with the full presentation of alkaptonuria, but we'll be drawing one together. And for now, just remember this. Remember the black pea in the diaper of the baby. Now for alkaptonuria, again, we're still in the same pathway. We have the phenylalanine and tyrosine pathway. Okay, but this is a rare metabolic condition involving deficiency in homogentisic acid oxidase. So this is the pathway we have. We're starting with tyrosine, again, phenylalanine to tyrosine, and then tyrosine will be converted after several steps into homogentisic acid. Now, normally, homogentisic acid would move to menyl acetoacetate. Okay, but the problem here is homogentisic acid oxidase enzyme is deficient. So when it's not working, wait, sorry. Having questions? Okay. So when this enzyme is not working, homogentisic acid would take another pathway. Instead of going into menyl acetoacetate, it would go into benzoquinose and form ochronotic pigment. Sorry, the word's not mean, but it's ochronotic pigment. What does this mean? Ochronotic pigment is basically black pigment, so it would cause discoloration. And hence, we have the three characteristic symptoms. First, we have the urine would contain elevated levels of homogentisic acid, also called alkaptone, hence the name. So alkaptone in the urine, alkaptonuria, it's oxidized to dark blue or black on standing. So when you take a test tube with the urine sample and leave it for some time, it would be oxidized and turn from yellow to dark blue. There will also be deposition of black pigment or ochronosis in the cartilage. And so the joints would look black. And we also have large joint arthritis. Okay, so for the other diseases or defects, the enzymes were clear. So for phenylalanine, we had phenylalanine hydroxylase. For albinism, we had tyrosinase. But here, this one is a bit weird. So okay, this is a bit dumb, but this is how I remembered it, and as long as it works. So we have homogenetic acid oxidase. First, we'll break it down. Let's take homo. So homo means same or similar. So for that, we're going to remember that everything is going to be black. So you have black urine, black joints, cartilage, and everything. And then we're going to talk about homocystinuria and other stuff. So you won't confuse the homogenetic acid and homocystinuria. So we have the word gen. Okay, so gen reminds me of the word gin. So gin are supposed to be scary. So you can imagine an old man with black urine, black joints, rusty joints, and everything. So this would be scary. So you can associate it like this. So when you see homogenetic acid, you can remember the black joints, the black urine. Black urine is alkaptone, hence alkaptonuria. So you can remember it that way. Okay. I think we're done with this slide. Next slide. Okay, so we also have the dark staining of the diapers. This can indicate the disease in infants, but usually the symptoms would appear later in life. So if it appears earlier, you can see the black staining of the diapers. And how can we solve? As we said, to prevent the accumulation, we need to decrease the substrate intake. So for example, here, the pathway starts with phenylalanine and tyrosine. So if we take less of these in the diet, we will decrease, if we decrease the tyrosine, we'll decrease the homogenetic acid and hence less ochronotic pigment. This means decrease the amount of pigment deposit in the tissues. Now, alkaptonuria is not life-threatening, but it's associated with arthritis. As we said, arthritis is the inflammation in the joints, and this would affect the patient. Now, this is the presentation. Okay. Here, as we described, the urine would start as yellow, but if you leave it for some time, it will get oxidized and form and turn black. Now, for the other presentations, we can wait 1 second. Okay. For that, we can imagine this. So this is a map, and from the word alkaptonuria, you can imagine. Alkaptonuria sounds like captain, so we can imagine a captain, for example. So this is captain's cap. Just imagine this is the cap for whatever. And what do we have? First, we have black urine, and then we have black joints due to the deposition of the cartilage, and then we have arthritis. So the joints are inflamed and they hurt. So you can imagine this guy. So for phenylketonuria, we had the baby with the mental retardation. For alkaptonuria, we have this guy with the black urine and the inflamed joints and everything. So yes, this is the image you can imagine. Now you can move to the next slide. To me, yes. This is the slide from Dr. Hanel's presentation. So we have, again, the urine, which turns black due to alkaptone, and it darkens when exposed to air. And okay, so we remember the black pigment deposition, and then the dark urine. And what is the enzyme affected? You have homogenetic acid oxidase. Now, okay, check one time. So we covered 3 metabolic defects: phenylketonuria, albinism, and alkaptonuria. Do you guys have any questions? Wait, let me check the chat. Okay, the like the ghosts and so on. Okay, so if all is clear, we can move on. Okay. Now, let's go back to this slide. So we covered this pathway, phenylalanine and tyrosine. Now we can move to a branched chain amino acid pathway, and for that we have maple syrup urine disease. Okay, let's go to the slide here. And for maple syrup urine disease, I want you to remember this image. So what can you tell from this baby? You can type in the chat. Yes. Yes. Okay. So you can notice the first thing you notice is vomiting, and then the baby looks tired. So there's a problem in muscle tone. And we'll be going over the whole presentation, but for now, remember the muscle tone, the baby looks tired, and there's vomiting. Maple syrup urine disease, remember this image. Okay. So it's another autosomal recessive disorder, and there's a partial or complete deficiency in branched chain keto acid dehydrogenase. Now, how can you remember that? Maple syrup urine disease. So we can imagine a maple tree, and a maple tree has branches. So what's affected? Branched chain keto acid dehydrogenase. So this pathway is for branched chain keto acids. So this is the pathway we have. This picture was not in Dr. Hannah's slides. I just added it so I can explain in this diagram. Okay, so what is the function of this enzyme? It decarboxylates the keto acids of leucine, isoleucine, and valine. So we can remember this again. All the methods I use are weird, so don't judge me. So for maple syrup, we imagine a tree. So we can imagine that this tree is alive. So we can think of the word live. But for now, we don't have an E, so we can ignore the last E. So we have a maple tree. Tree has branches, branched chain keto acid dehydrogenase, and tree is alive, live. So imagine LIV, we have leucine, isoleucine, and valine. So these are the amino acids involved in this pathway. So you can see leucine, isoleucine, and valine. They will be converted into alpha keto acids. Alpha keto acids using branched chain keto acid dehydrogenase would be converted into other stuff. So if this is not working, wait, let's make it the laser pointer. Okay, so if this is not working, everything behind it will start building up. And hence, these branched chain amino acids, leucine, isoleucine, and valine will build up. And the alpha keto acids will start building up too and accumulate in the blood. Now, what are the effects of this disease? First, from the name, you have maple syrup odor of the urine, and this is mainly due to isoleucine. Now, what about the somatic symptoms? Now, we have changes in muscle tone, ketoacidosis, vomiting, feeding problems. So you can go back to this picture and see changes in muscle tone. You have feeding problems, vomiting, in addition to ketoacidosis, and there are neurologic problems that can result in coma. The neurologic problems are due to leucine. Maple syrup odor is due to isoleucine. Now, if we delay the treatment, there will be intellectual disability, again, CNS effects. And if we do not treat this disorder or this defect, the disease is fatal. Okay, so we said maple syrup urine disease is due to deficiency in branched chain keto acid dehydrogenase. What is something important about this enzyme is it needs these 5 main coenzymes or cofactors. The famous mnemonic for these is CLC for Nancy, or the lovely coenzymes for nerds, or whatever you like, really. But branched chain keto acid dehydrogenase needs those 5 coenzymes, which are B1, B2, B3, B5, and then lipoic acid. B1 is thymine pyrophosphate, B2 is FADH2, B3 is NADH, B5 coenzyme E, and lipoic acid. So we said we have 3 enzymes requiring those cofactors. One of them is branched chain keto acid dehydrogenase, which is needed for conversion of valine, isoleucine, and leucine into propionine CoA. You also have alpha ketoglutarate dehydrogenase, which is a part of the Krebs cycle, and pyruvate dehydrogenase, again, in the cellular respiration pathway. So these three require those 5 cofactors. Okay, so we covered microcircular disease. We finished the branched chain amino acids pathway. Now we're going to move to this one. We have valine, isoleucine, methionine, and threonine pathway. And for that, we'll be discussing. Yes, questions? Okay. Can microcircular disease cause seizures? Okay, let me go back to the slide 1 second. Okay, so we said it causes neurological problems. So I guess this includes seizures. I'm not sure if it's exactly seizures, but we said that due to accumulation or rise in leucine, there could be neurologic symptoms. Any other questions? Okay. Okay, I'll move to the next one. So in the next one, we have methylmalonic aciduria and propionic acidemia. Okay, so here we have 4 amino acids. We still have valine and isoleucine from the previous pathway, but in addition to that, we have threonine and methionine. So those 4 amino acids are involved in this defect. These 4 amino acids converge into one pathway, the propionic acid pathway. Now this pathway, as I just mentioned, we have valine, isoleucine, threonine, and methionine, but also odd carbon fatty acids require this pathway. So when we break fatty acids, we break them into pieces of 2 carbons, but if it's odd chain, we'll end up with a piece with 3 carbons. So this one with 3 carbons is called propionic acid, hence it converges into the same pathway. Now this pathway would require 2 main enzymes, propionyl-CoA carboxylase and methylmalonyl-CoA mutase. Now, I guess those are relatively easy to remember because they're related to the names of the defects themselves. You have the methylmalonic aciduria related to methylmalonyl-CoA mutase, and propionic acidemia related to propionyl-CoA carboxylase. We're going to go over the pathway in a bit. But for now, okay, so the failure of metabolizing the keto acids due to deficiency in those enzymes would cause neonatal ketoacidosis. So we have these 4 amino acids, they'd be converted into keto acids. These keto acids usually are supposed to continue through the pathway using those 2 enzymes to give us other products like 6-methylCoA, and they'll go through another pathway. But in the absence of those 2 enzymes, whatever is before, again, will start accumulating. So the keto acids will accumulate, causing neonatal ketoacidosis. Now, again, how do you solve this issue or to treat the deficiency? We give them less of the precursors. So we give less valine, isoleucine, threonine, and methionine, or a diet low in proteins. So this is the pathway. We said we have these 4 amino acids involved. They will all converge to form propionyl-CoA. Now, propionyl-CoA would be converted into methylmalonyl-CoA. This requires the enzyme propionyl-CoA carboxylase and the cofactor vitamin B7 or biotin. Now, a methylmalonyl-CoA would get converted into succinyl-CoA, and this requires methylmalonyl-CoA mutase and the vitamin B12. So remember those. So usually carboxylase enzymes require B7, so this is easy to remember. Propionyl-CoA carboxylase with biotin. And for methylmalonyl-CoA mutase, just remember it requires vitamin B12. Now, if we have this affected, if propionyl-CoA carboxylase is affected, whatever is before it will start accumulating. So we have propionyl-CoA accumulating. So what disease or what defect would occur? Have propionic acidemia, because this will start building up. However, if we have methylmalonyl-CoA mutase affected or deficient, methylmalonyl-CoA will start building up. This will get converted into methylmalonate. And what will this cause? Methylmalonic aciduria. Questions? Okay, nothing in the chat. So, okay. So I didn't find photos with the full presentation, but we can use these. For methylmalonic aciduria, remember that the patient would have grayish pallor, like in this image. There will be discoloration of the skin into gray. There will be scaly dermatitis and hair loss or alopecia. So this is for methylmalonic aciduria. Propionic acidemia, on the other hand, first remember it's common in Saudi Arabia. And this baby here, I don't think you can tell, but she suffers from propionic acidemia. Now, what are the symptoms of propionic acidemia? You have poor feeding, vomiting, dehydration, acidosis, hypotonia, seizures, and lethargy. So the symptoms are not really specific, but other things in the question would guide you, like the enzyme mentioned or the cofactor and so on. The effects of propionic acidemia quickly become life-threatening. So I think that's it for those defects. Now we have another checkpoint. So far we covered phenylketonuria, and the enzyme affected is phenylalanine hydroxylase. We covered albinism with the tyrosinase enzyme. We covered alkaptonuria with homogentisic acid oxidase enzyme. Then we moved to maple syrup urine disease with the branched chain keto acid dehydrogenase, and then methylmalonic aciduria with propionic acidemia. Any issue with any of those? How can they ask about this? They can give you a scenario. They can tell you that, for example, propionyl-CoA carboxylase is deficient, and the patient started showing dehydration, acidosis, low muscle tone, and so on. But as I said, the presentation is not really specific, and this means usually they'll give you something to show what the pathway is. Or they could mention the enzymes. They could either the amino acids, sorry. They could mention the amino acids or the pathway that's affected. So here, for example, propionic acidemia, we have propionyl-CoA carboxylase. Or they could get it in an SAQ, for example. And yes. But for example, I think they'd focus more on the other ones like phenylketonuria because it has very specific presentation, and like the phenylketones and the mental retardation. So yeah, I think that's it. Any more questions? We only have one defect left, and then we'll move to questions. So if you have any problem with the other, 1 second, something in the chat. Clear. Okay, so we only have homocysteine left. We're gonna cover this. Okay, so here is homocysteine. Again, there was no photo with the full presentation, but we can work with this for now. So in this image, just remember there is the dislocation of the lens or ectopic lens. We have other presentation in the coming slide, but for now, remember the ectopic lens or homocystinuria. Now, this is a group of disorders involving defects in the metabolism of homocysteine. So from the name, homocystinuria, homocysteine will start accumulating in the urine. So there are high plasma and urinary levels of homocysteine. Now, the individuals who are homozygous for this enzyme exhibit dislocation of the lens, ectopic lens, like we said, like we showed in this image. The lens is dislocated. We also have skeletal anomalies. You can see here, the patient would have long limbs and long fingers. So the ectopic lens and the skeletal anomalies are also found in Marfan syndrome. Marfan syndrome is a syndrome affecting the connective tissue and the collagen. It's not involved with amino acids, but it would have similar presentation with the ectopic lens, long limbs, and long fingers, but it's a separate disorder or syndrome. Here, in addition, we also have intellectual disability, and it's very important to remember there's increased risk for developing thrombi or blood clots. So thrombosis is the major cause of early death in these individuals. Okay, so how can you remember this? You can use any dumb method you like. So, for example, you can remember homocysteine would have the word cyst in it. No, this is not scientifically correct, but just to remember it, you can remember what's a cyst. A cyst is basically a lump or a sac filled with fluid. So you can imagine a cyst clogging the artery and causing a blood clot, for example. Now, again, this is not correct. This is just to remember. So just remember when you see the word cyst in homocysteine, remember blood clots developing thrombi, or you can remember the long limbs. So the blood has to travel for very long distances. It gets tired and then starts clotting, for example. So homocystinuria, long limbs, long fingers, developing thrombi. Another thing you have to remember is that homocysteine has a sulfhydryl group. This group can form disulfide bridges with the proteins. Now, how does this affect? The proteins will be damaged. They will alter the shape of the protein, alter the function of the protein, and again, it will cause these symptoms: the dislocation of the lens, the skeletal anomalies, intellectual disabilities, and the thrombus. Okay, now homocysteine is part of the methionine pathway, as we mentioned earlier. So let's go over the pathway. Okay, so Dr. Hannah used a different image, I know, in her slides, but this is the exact same thing. I just thought this one is clear to explain it. So we'll start with methionine. Methionine, you can take it through the diet, for example. Methionine would be converted into SAM. Now you can see here, 1 second. Yes, SAM stands for S-adenosyl methionine. Now it's very important to remember that S-adenosyl methionine is a methyl donor. So you can see here, it donates or gives a methyl group, CH3 group, to any molecule, forming SAH. So this is a methyl donor. We got rid of a methyl group to get SAH, which is S-adenosyl homocysteine. This will get converted into homocysteine. So you can notice that from methionine to get homocysteine, we lost a methyl group. Now, homocysteine now has two paths it can go through. It can either take the first route, which is to get converted into cystathionine, then cysteine. And for this reaction, we need cystathionine synthase. So to synthesize cystathionine synthase. And for that, we need vitamin B6. Or it could go back to this pathway, homocysteine, to regenerate methionine. Now we said from methionine to homocysteine, we lost this methyl group. So we need to add it back. So for that, we need 5-methyl tetrahydrofolate to give us the methyl group and vitamin B12. And the enzyme involved is methionine synthase. So we mentioned several enzymes and several vitamins in this lecture. So first for propionyl-CoA carboxylase, we mentioned which enzyme, which vitamin, it said biotin. And then for homocysteine to cystathionine, we need vitamin B6. And for methylmalonyl-CoA carboxylase, methylmalonyl-CoA mutase, and methionine synthase, we need vitamin B12. So we mentioned biotin, B6, and B12 in this lecture. So we said homocysteine has two pathways. If either of those is affected, homocysteine will start building up. So for homocystinuria, we have two paths. Two enzymes could be affected. First one, and the most common cause of homocystinuria, is a defect in cystathionine synthase, which converts homocysteine to cystathionine in the presence of B6. So this is the pathway. So here you have homocysteine to cystathionine in the presence of cystathionine synthase and B6, which is the same one here. This is the most common cause. And then we have the other pathway, which is the methionine synthase pathway, also called homocysteine methyltransferase. So this puts the methyl group back on homocysteine to regenerate methionine. This requires two coenzymes, methyl tetrahydrofolate, to give us the methyl group to attach it back to methionine, to form methionine, and vitamin B12 or methylcobalamin, which is this pathway here. So either of those could be affected to cause an increase in homocysteine. So a deficiency of this enzyme, accumulation of homocysteine, causing homocystinuria. So this way we covered all the metabolic defects in Dr. Hannah's lecture. Do you have a problem with any of those before we can proceed? There's nothing in the chat. Everything's clear? Okay, we only have a few questions, only 3 questions, I think. Yeah, well, let's start again. Okay, this is the first question. Newborn has milky white skin, white hair, red appearing eye color. Disorder most often results from a defect in which one of the following enzymes? Yes, okay. So can anyone tell me what is the, yes, good. What is the disorder defect? Yes, albinism. And the enzyme affected is tyrosine, the tyrosinase enzyme. So, okay, this one was easy. Now let's move to the next one. 12-year-old boy brought to the pediatrician because of behavior problems noted by the parents. Brittle and coarse hair, red patches on the skin, long, thin arms and legs, like Marfan syndrome patients, have scoliosis, displaced lens, muscular hypotonia. There's an elevation in which one of those? We have two E's. E, E, E. Okay, good job. So what is the defect here? Yes. So the defect is homocystinuria. The main sign is the long, thin arms and legs and the displaced lens. The other stuff are just general symptoms. They won't help us identify the defect. So as long as you remember that the long, thin arms and the displaced lens are related to homocystinuria, it's easy to figure out the answer. Now, one last question. Okay, so this is a long scenario, but again, you can find keywords to help you identify. So you have 50-year-old man comes to the clinic for evaluation of chronic back pain. Is a librarian notes that the pain is localized to the lower back, and long day standing does not improve with ibuprofen. Significant. There's osteoarthritis, underwent total hip replacement. Temperature is 37, pulse is 86, respiration is 16, blood pressure is 125/85. There's bluish pigment deposition in the sclera. There's hyperpigmentation in the axillary and inguinal regions. Range of motion is limited. Now I want to know the disease or the defect and affected enzyme. Okay, I have F and E. Other answers? B. A. Okay, we have different answers for this one. This is a bit challenging, makes sense. Okay, our host said scary. Okay, good job. طيب. Correct answer. We have one correct answer. B. So the defect here is alkaptonuria. How can we tell? Okay, let's annotate the main stuff. Okay, so first thing we're going to notice is that he's 50. Okay, there's chronic back pain, and then this is just to fill the question. So we have ibuprofen, we have osteoarthritis. So whatever is here is just extra information. We have pain, have osteoarthritis, family history, temperature is normal, pulse is almost normal, respiration normal, blood pressure almost normal. So a bluish pigment. Okay, so here we have hyperpigmentation in the axillary and inguinal regions. So we said we have arthritis, we have hyperpigmentation. So we mentioned we included several photos associated with every defect or every enzyme, every deficiency. So yes, blue pigment is clear too. Okay. So which one of the images we mentioned goes with this scenario? Yes, the captain. So we have the captain with the dusty joints, with the hyperpigmentation. They didn't mention the black urine, but they mentioned hyperpigmentation. So and osteoarthritis. So they mentioned the two other symptoms. They don't have to mention the urine itself. So this means we have alkaptonuria. And what is the enzyme affected? Tyrosine hydroxylase is in a different pathway. We have homogentisic acid oxidase, as we mentioned. You have homo here. Okay. You have homo. everything would be black, the urine, the joints and everything. And Jen from the scale, the gym, everything. Okay. Why not homocystinuria? Because you said homocystinuria, what would be the presentation? Yes, in homocystinuria, yes, exactly, like Marfan. So they would have the long limbs, they would have the thrombi clotting, and so on. So we would yeah, we would cancel a homocystinuria, so no C and no D. PKU or phenylketonuria. Okay, so we said phenylketonuria can anyone tell me the symptoms or signs of phenylketonuria other than phenylketones in the urine? Hyperpigmentation, what else? Yes, exactly, mental retardation. So mental retardation would appear very early in life, which is why we said we have to screen the neonates. So the symptoms won't start in a 50-year-old man with chronic back pain. So you should read the full scenario. So here the patient presenting is 50-year-old with chronic back pain. In phenylketonuria, first they'd usually be a neonate or a baby with mental retardation, phenylketones, hyperpigmentation, and so on. The baby won't wait till it turns 50 and then start presenting, which means we can also exclude PKU and homocystinuria, which leaves us with alkaptonuria. Now, what is left is knowing the enzyme affected. So, as we said, enzyme affected in alkaptonuria is homogentisic acid oxidase. And this was our last question. So, okay, wait, let me move the annotation. So this is one very pretty summary done by our host, Shahd Murshid. This basically summarizes everything in the lecture. The metabolic defects starting with phenylalanine and tyrosine pathway, then the branched chain amino acids, then valine, isoleucine, methionine, threonine, and finally the methionine defects. So this has everything, and you can use it. And we also have this one. This table was provided by Dr. Hannah in her slides. I think a senior prepared it, or doctor, I'm not really sure. But this is, if you prefer tables over summaries, you can even use this. And that is it for our lecture today. Do you have any questions? I'm sure the questions would be really easy for this lecture. Okay. Oh, inshallah, in this session, I mentioned everything you need to know. I went over Dr. Hannah's slides and included some images that would, inshallah, help you remember the stuff. So if you focus with me, inshallah, I mentioned everything, and the questions will hopefully be easy. And your TPL is on Sundays, huh? So inshallah, it's gonna go well. Good luck. And if you have any questions in the future, don't hesitate to contact me by email or phone number. See you too.